Your immune system can kill cancer. So why doesn't it? Your immune system is capable of recognizing and destroying cancer cells, yet many tumors grow in plain sight. The reason is not always immune ignorance. Sometimes, the immune system is actively switched off. Many cancers achieve this by hijacking a key immune checkpoint pathway, the programmed DEF1 and programmed DEF ligand 1 pathway. Immunotherapy has remarkably transformed modern oncology and now forms frontline therapy for cancers such as melanoma and non-small cell lung cancer. However, only 20 to 40% of patients truly benefit, with many experiencing significant toxicities and side effects. To understand both the success and the limitations of these therapies, we must first examine the underlying biology. Under normal conditions, dendritic cells continuously scan the tumor microenvironment for tumor-associated antigens. Once captured, dendritic cells internalize the antigens and migrate to secondary lymphoid organs, where naive CD8-positive T cells reside. Dendritic cells load their tumor antigens onto MHC class I molecules via cross-presentation and present them to antigen-specific CD8-positive T cells. This priming of the T cell receptor with a peptide MHC complex constitutes signal 1. Meanwhile, co-stimulation between CD28 on the T cell and CD80 or 86 on the dendritic cell provides signal 2. Together, these signals activate key transcription factors, including NF-kappa B, NFAT, and AP1. This drives interleukin-2 production, essential for T-cell activation, proliferation, and survival. Cytokines in the microenvironment then deliver signal 3, promoting differentiation into cytotoxic T lymphocytes. These effector T cells traffic to the tumor, where they recognize tumor cells presenting the same peptide MHC1 complex, and release perforin and granzymes to induce apoptosis. In principle, this immune surveillance system should effectively eliminate emerging tumor cells. However, T cells are highly potent. To prevent excessive tissue damage and autoimmunity, the immune system evolved inhibitory checkpoints that function as molecular brakes to essentially switch T cells off. One of the most important of these is programmed DEF1 or PD-1. PD-1 is a co-inhibitory immune checkpoint receptor expressed on activated and chronically stimulated T cells. When PD-1 engages its ligand PD-L1, T cell activation signals are actively suppressed. Physiologically, this pathway helps terminate immune responses after infection and maintain peripheral tolerance. But somehow, tumors have found a way to exploit it. Many cancers upregulate PD-L1 on their cell surfaces, often in response to interferon gamma produced by cytotoxic T cells within the tumor environment, or activation of oncogenic pathways such as PI3K ACT and MAPK. When PD-1 binds PD-L1, the phosphatase SHP2 is recruited to the PD-1 cytoplasmic tail. This leads to dephosphorylation of key components within the T cell receptor signaling cascade, as well as the co-stimulatory receptor CD28. As a result, interleukin-2 production falls, leading to impaired cytotoxic function of the T cell. Over time, these T cells enter a dysfunctional state known as T cell exhaustion. The immune system has not failed. It has been actively suppressed. In 2018, James Allison and Tasuku Honjo were awarded the Nobel Prize for discoveries that would ultimately revolutionize cancer therapy: immune checkpoint inhibitors. These are monoclonal antibodies that block PD-1 or PD-L1, releasing this molecular brake. By restoring T-cell activity, this emerging form of immunotherapy enables renewed recognition and destruction of tumor cells. Immune checkpoint inhibitors have been shown to be very successful, and the clinical impact has been dramatic. Because these therapies engage the immune system itself, they can generate durable immunological memory. This means that even after initial tumor control, memory T cells may continue to surveil the body, providing long-term protection against relapse. The long-term impact of PD-1 inhibitors is perhaps best illustrated in advanced melanoma. Prior to the introduction of immunotherapy, a phase 3 trial published in 2011 showed that patients with stage 4 melanoma treated with chemotherapy had a median survival of only around 9 months. Strikingly, a recent study published in 2025 following the 10-year Checkmate 067 trial demonstrated that patients treated with PD-1 inhibitor nivolumab had an extended median survival to over 3 years, with 37% of patients alive at 10 years. These findings provide compelling clinical evidence that immune checkpoint inhibition can induce durable, long-term tumor control. In spite of that, the majority of patients still fail to achieve prolonged survival. This highlights a major ongoing challenge in identifying which patients are most likely to respond to immune checkpoint inhibitors. The limited response rate reflects the complex biology of tumor immune interactions. For example, resistance to PD-1 and PD-L1 inhibitors has emerged as a major clinical challenge faced by most patients. Resistance may be primary, where tumors fail to respond to treatment from the very beginning and are seen in cold tumors, lacking sufficient T-cell infiltration. Adaptive, where tumors compensate and upregulate alternative immune checkpoints. Or acquired, where the initial response is followed by tumor progression or recurrence, often driven by tumor evolution or immune escape mutations. One strategy to overcome resistance is dual checkpoint blockade. In the CheckMate 067 trial, combinational therapy of the PD-1 inhibitor nivolumab with ipilimumab, an inhibitor targeting another crucial immune checkpoint protein, CTLA4, produced an even higher response rate, with a median survival of 6 years and 43% of patients alive at 10 years. These findings establish dual checkpoint inhibition as a powerful modern approach in cancer immunotherapy. Despite these advances, patient responses to immune checkpoint inhibitors remain considerably variable in clinical practice. This heterogeneity in outcomes has driven an intense search for predictive biomarkers that can identify which patients are most likely to benefit from therapy. To help address this variability in response, PD-L1 testing has become an important clinical tool for patient selection. PD-L1 expression is measured in tumor tissue using immunohistochemistry, allowing clinicians to estimate the likelihood of response to PD-1 or PD-L1 checkpoint inhibitors. Higher tumor PD-L1 expression is generally associated with improved response rates to PD-1 and PD-L1 inhibitor agents like nivolumab, pembrolizumab, and atezolizumab. As a result, PD-L1 testing is now routinely used to guide first-line immunotherapy decisions in many clinical settings. However, PD-L1 is an imperfect biomarker, as its expression alone does not fully predict therapeutic benefit. A study on non-small cell lung cancer with pembrolizumab showed that even patients with low or absent PD-L1 expression responded to checkpoint blockade, while over half of the patients with high PD-L1 expression still failed to achieve durable responses. This emphasizes the need for more robust predictive biomarkers. Furthermore, immune checkpoint inhibitors are associated with significant side effects. In 2024, a systematic review encompassing over 300,000 patients reported immune-related adverse events in approximately 40% of patients, with 20% experiencing severe toxicities. These numbers were found to be even higher in combined therapy. Because checkpoint inhibitors release inhibitory brakes on the immune system, off-target damage to normal tissues is likely to occur. These toxicities reflect the delicate balance between effective anti-tumor immunity and the risk of autoimmunity. Looking ahead, the future of cancer immunotherapy will depend on more precise patient stratification and rational combination strategies. Emerging biomarkers are being actively investigated to improve the prediction of therapeutic response beyond PD-L1. Next-generation approaches such as bispecific antibodies and personalized immunotherapy aim to overcome resistance and extend durable benefit to a larger proportion of patients. In summary, many tumors evade immune destruction by exploiting the PD-1/PD-L1 checkpoint to suppress T-cell function. Immune checkpoint inhibitors work by releasing this molecular brake, a strategy that has transformed cancer therapy, yet still faces important biological and clinical challenges. What began as an attempt to release the brakes on the immune system is now evolving into an era of precisely engineered anti-cancer immunity. Cancer doesn't always hide. Sometimes it presses the off switch.